right, good morning, everyone, and welcome back to the second session of the breakfast at UMHealth. All right, so I'm your moderator for this session, and we're about to dive into a topic that resonates with millions around the world, which is low back pain. So it's my pleasure to introduce our next speaker, Associate Professor Dr. Anwar Suhaimi, who is a leading figure and a driving force in advancing musculoskeletal and pain rehabilitation services in UMMC and also across Malaysia. So Professor Dr. Anwar has contributed extensively to the development of national guidelines, creating and refining digital tools to improve pain management, especially in the musculoskeletal area. So today, he'll be sharing insights that I guess will promise to change how we think about low back pain, the rehabilitation, and the spinal health in general. So his talk is titled Cracking the Code on Low Back Pain from Electrical Chaos to Biotensegrity and Fascia Integrity. I'm sure everybody's really wondering what that is all about. And so, Prof. Anwar, the floor is yours. Thank you.
Thank you very much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. Thank you, Professor Mazlan, for the very kind introduction. Now, before I begin, can I just check that I'm audible and visible to the audience, please? All right, so we're gonna dive into an interesting topic. Interesting because not just because of the how obviously common it is, and I think just second to headache, back pain is almost universal. And today we'll go on how to on cracking and on what's the big fuss about low back pain. And I hope by the end of today's session, we'll look into how low back pain is not just very relevant and how it still cripples the healthcare system. And maybe perhaps we should look beyond or get a bit more innovative with the way we look at back pain. And hopefully there's light at the end of the tunnel with some novel targets that I hope to shed some light on by the end of this session. Okay, so to begin, this is a representation of a survey done just before the pandemic. Now, if you look at the map in all the countries colored in crimson red, the color of blood, these are the countries where low back pain is still the #1 cause of disability, to the point that if you were to gather all the individuals with low back pain and form a country, probably call it Kingdom of Low Back Pain, it will be the third most largest by population. Now, that's how significant we are. We are talking about 620 million individuals reporting chronic low back pain in 2020. And that has gone up to, or is projected to go into 800. Oh, I'm sorry, it's in presented view. Okay, let me just undo that again, and I'll just reshare. Okay. How about this? And how about...
Yes, okay, that's good. Yes, now
how's this, Prof?
No, it goes back to the
presenter
view, yeah.
Okay, that's fine, no worries. I'll just have to present from memory. Now, Prof. Mazlina will have good time doing cognitive assessment on me. Okay, so 600 and 850 million approximately by 2050, and that's a significant number. Now, it's not just about figures, it's about how this drains the healthcare resources. So in Malaysia, it's estimated about 12 to 84% of individuals suffers from low back pain. And nursing and also drivers scores the highest. So this is quite interesting because drivers used to be what we know them as, people who drive people around. But now with the advent of e-hailing and all these services that we need, what we can get on Grab and the likes of it, you have more and more people being exposed to this risk. And risk factors extends well beyond what we traditionally know or what we learn in medical schools. So it's not just about BMI. Now things like mental health comes into picture, and obviously ergonomics. In comparison, the rate that United States is spending for low back pain is exceeding their inflation rate, which is a bit of a joke. And there is also the hidden losses that we sometimes do not account for. So things like absenteeism and early retirement, which I have personally seen in my own practice, is one of the costs that we should consider in low back pain. So now, how are we doing with the diagnostics and why are we falling short? One of the reasons is because it is very, very important for us to remember that imaging does not correlate with symptoms. There are many patients who come in with florid radiographs, but relatively low symptoms, and vice versa is very, very true. So relying on imaging alone to diagnose low back pain is probably going to lead to a lot of frustration, a lot of unnecessary procedures, and a very delayed referral for things that could have been done earlier for the patient, for example, rehab. And there is no specific markers for chronic low back pain, especially. So you cannot order a test in the lab or anything or draw blood. But what we have right now mainly are questionnaires or tests or clinical examinations that can be used to rule out rather than rule in causes of low back pain. So what happens is patients end up in a therapeutic roulette, let's try this, or let's try that, or that doesn't work, let's try this again. And it ends up being a cause of frustration for both patients and also the treating doctor. So then results in treatment disparity. To the right is a picture of our National Clinical Practice Guidelines for the Management of Low Back Pain. Now, up to this point, there are at least 200 listed treatments for low back pain. And out of these 200, very few are actually head-to-head RCT level. So we have limited evidence of what works for patients with low back pain. Now, and there's also over-reliance on medications, and this has led to the opioid epidemic. Once used to be said over the seas, but you can definitely now find it in our own backyard. So there is a need now to go into mechanism-based care rather than just basing it on symptoms. So this then sort of lead my team from rehab medicine as well from primary care medicine led by Dr. Tun Firzara actually looked into stratifying patients based on their psychological makeup. So we use the Start Back tool, which looks at, amongst other things, presence of anhedonia, depression, anxiety, low mood, and we stratify patients based on this for urgency of back care or back pain management. The results are promising. We can see satisfaction from the point of view of the patients, but it is yet still a diagnostic dilemma on the doctor's side because the patient still needs to be sorted out. Yes, they see us faster, but we end up doing the due diligence of finding out why they have low back pain, whether this should be treated the way that it's being treated right now. Anyhow, so this led to, necessity is the mother of invention. I wouldn't claim that I am the inventor of what we are going to discuss in the second part, which is the electrical chaos. But back in the 1970s, late 1970s and early 1980s to be specific, a few scientists begin to look at low back pain, obviously because it's such a common phenomenon that's affecting mankind, I guess, if you would go even back to the ancient times. So what they did was they stuck electrodes on patients' back with back pain, and they asked the patient to exacerbate their pain by moving forward and backward. And lo and behold, there was a significant pattern found, and this pattern differs between patients with and without low back pain. And this is what we are looking at as flexion relaxation phenomenon of FRP. So if you look at the image on the left, which is the pictorial representation of the EMG, surface EMG wavelets, is a non-invasive way of detecting electrical currents in the muscles. So specifically, we're looking at paraspinal muscles, and you can liken this to the ECG of the heart. So during forward flexion, there was an actual phase where there was electrical silence. So you can see that's a straight line across during the relaxation phase. And then again, once the patient goes up from forward flexion to upright extension, you will see that there is again a pattern of muscle activation and then electrical silence. Now, they found that in patients with low back pain, or rather, they found that when there is abnormal phase of this relaxation, there is associated increased back pain and decreased range of motion. And this phenomenon called the FRP is what we are interested in. So it was left at just a scientific finding until our own innovator and academic staff, Professor Fatima Ibrahim, who I had the pleasure of meeting with and learning from the Department of Biomedical Engineering, actually did a study on Salat, which is the Muslim prayer routine. And she was not just focusing on the back, she was focusing from the brain and all over the body in detecting electrical currents. And when she did this movement, which is now represented to your right. So the movements of the Muslim prayer can be divided to these three main forms, which is standing, forward flexion, prostration. So she found again at the lower bottom, you can see when the subject is transiting from standing to forward flexion or ruku', you can see there's again the reproduction of the electrical silence. Now, very intrigued by this, she then continued to just looking at this and found, and then developed a therapeutic exercise program together with Dr. Ramizan Abdurrahim, which was our academic staff in the Department of Rehab Medicine. So this became a full, you can actually read about this more in her Salat, study in Salat Science, the whole set of books in UM Publishers. So amongst things that she looked at was also erectile dysfunction, cardiac disease, and also low back pain. And she was looking into how we can use Salat movements and how it modulates electrical currents in the body. Very interesting read. So when I stumbled onto that publication, I was very intrigued. So I decided to do this study myself. Now, we are not just looking at pain. As a rehab physician, I will be very interested to look at disability, because a lot of times we meet patients who are in pain, but relatively functional. So our study, in summary, compared between patients who self-reported back pain and those without. We did the same movements, and yes, we found flexion relaxation phenomenon was reproducible in these patients. So those without back pain had electrical silence, and those with back pain had electrical chaos, hence the title of today's morning's talk. And our literature, and we were able to then also correlate the level of the FRP, flexion relaxation phenomenon, to an index, and the index correlates very well to the also self-reported Oswestry Disability Index, which is what you see on your right. And Oswestry Disability Index is able to actually categorize patients based on how severe or how disabling the low back pain is. So we are now able to correlate FRP to pain and FRP to disability. Our literature review also shows that out of 7 studies reported globally, FRP has pretty good sensitivity and specificity, okay, and also quite a good moderate to excellent diagnostic accuracy. So it looks quite promising. So to cut the long story short, a proof of concept became a prototype. A prototype was then commercialized. So we were on air talking about it on Astro Awani, and this is how the device looks like. It's under non-device care. Cute little device that goes on your back, and basically it remotely monitor low back pain. So you can liken this to a halter. Now we added a few technology. You can see this on your phones. You can record it just like how you use a smartwatch to record the your heart rate and other parameters that you like to see. So a few public appearances about that. So how are we using this technology right now? So it's now being used to detect low back pain and monitor, and especially so in rehab, in rehabilitation, we use concept of biofeedback. So if the patient is contracting or relaxing a muscle appropriately, you can see that visually, and that serves as a visual cue that helps to reinforce behaviors. But what we are hoping for in the future is going towards monitoring the patients out when they are working, or as I mentioned earlier on, there are some occupational hazards, or when they are exercising at home, and we can see whether they are really exercising what they're supposed to exercise, and they're relaxing what they're supposed to relax. And FRP now, as I said earlier on, you can differentiate between those who have and do not have low back pain. So probably we are going toward diagnostics. This needs more time and more data, obviously, and even prognostication. So moving on, the last bit of today's sharing is looking at the good old fascia. It's really an interesting creation, if I can say that. In the anatomy books, you probably just get a paragraph or one page about fascia, and probably the only other time you heard about fascia is fasciotomy for compartment syndrome. And I really did not pay much attention to it until I began to investigate and look at patients who presents with quite abnormal findings. So that's still in publication. We'll probably talk about it at the end of the talk today. So fascia, as we are taught, it's like an envelope. It covers up a muscle or a group of muscles. But what it really does, it goes in between, it interlinks different parts of the body. And as we know more, this creation doesn't cease to fascinate me. So it's really a hidden connection. And if you take a microscopic view of fascia, and that's what you are seeing now on the right hand side, that's how a fascia looks like really up close. It's actually a web, not just a thin sheet of soft tissue. It's actually a web that not just wraps, but gives structural integrity and shape to our body. It facilitates movements by gliding because it's actually 70% water and hyaluronic acid. So it does facilitate movements. It can dry up, and I'll talk about that later. Now, we must remember fascia is not just a wrapping, it provides nutrition because blood vessels run through it, capillary runs through it, and also waste clearance because don't forget lymphatics. Now, nowadays we talk about lymphatics a bit more than when we used to, or maybe that's just my ignorance now, not just from medical, even from beauty, people talking about gua sha, lymphatic drainage, and so on and so forth. So waste clearance and essentially the function of the living cell depends on fascia. And most importantly as well, the neurosensory function. We must remember 80% of the sensory nerves terminates within the fascia and a lot more passes through fascia. So fascia really can contribute to pain perception and pain modulation. Okay, biotensegrity. Now, essentially the concept of tensegrity was first described by Buckminster Fuller. It's basically describing how all the soft tissues in the body interact with itself and with the bone, which we traditionally see it as a solid structure that supports. It is an interaction between tensile strength and support. Okay, so that's why it's tension and compression network. If we apply this to architecture, and that's when you get the beautiful sculpture here by Snelson, and there's many more examples if you were to Google him. If you look quite closely, none of the steel beams are touching each other. They are all floating in air and held in place by the tension of the wires. And you can see similar structures in the geodesic domes and a few other bridges. This is how the structure is held in place because of tension and balance it with compression. Applying this concept is to biological structure is biotensegrity, where we describe. So in this, we describe the relationship between soft tissues and bone. So in the past, we were saying, okay, a limb moves because muscle contracts. Now with biotensegrity, the limb moves because the tension across the joint changes, and the tension can change because of soft tissues like muscles, ligaments, and obviously fascia. So we're looking specifically in low back pain at the thoracolumbar fascia, which I'll dive into quite soon. So fascia pathology relates to its function. So its function is, like I said earlier on, is beyond just a structural wrapping. It is a force transmission system, and you can see it integrates into so many other systems in our body that it will influence its function as well. So to illustrate this, you have a video of what a biotensegrity structure like. So just have a look at that. So you can see that the forces acting across there is not just about who's being compressed, but also who is transmitting the force. And that is essentially tensegrity in process. So we have a lot of that in our body, and I'll show it to you in a while. I've had the pleasure of participating in dissection. So we had one in Thailand, and basically this is the video on the right is showing what it would look like if you were there with me. And a lot of our understanding about the fascia and its function comes from the work of Carla Stecco and colleagues. So you can see that muscles are attached to the fascia, nerves travel within it, blood vessels as well, and lymphatic. So essentially, I'm sorry, just got a bit excited there. Essentially, we're looking specifically for low back pain. We're looking at the dissection. So if I take you through to the dissection, if I take off the skin subcutaneous tissue, you have already begin to see the posterior layer of the thoracolumbar fascia marked here, which is connecting to the latissimus dorsi. And if I take off latissimus dorsi, you also then see instead of the superficial, the deep layer of let me use my laser pointer, please. The deep layer of the thoracolumbar fascia, which is on top here. So this is a superficial, and if I take off latissimus dorsi, you see the deep layer of thoracolumbar fascia in integrating itself to superior serratus posterior inferior, and even the paraspinal muscles. And if I take off that layer as well, then you begin to see the aponeurosis of the erector spinae, and all of that can be summarized into this pictorial diagram. So we have essentially three layers of thoracolumbar fascia. The superficial one just below the skin over the erector spinae, the middle one between erector spinae and quadratus lumborum, and the anterior one, the deepest most in front of the quadratus lumborum between quadratus lumborum and the kidney. And you often can see that quite well on an MRI image. So again, here's the posterior layer, And here's the middle layer, and this is the anterior layer between corpus lumborum and the kidney. So with that in mind, let's go into a bit of anatomy. So the superficial layer of the thoracolumbar fascia, I'll show you some examples clinically so you can appreciate its significance. But the deeper layers needs you to have a bit of a dissection. So this is the dissection down to this level here between, which is shown in this circle. So what you're seeing right now is the middle layer of the thoracolumbar fascia. And what I want to address your attention is these arches that is being formed by the middle layer of the thoracolumbar fascia. You can actually see the nerve roots, the lumbar nerve roots coming out in between and forming the lumbar plexus. So here again, you can now appreciate how close is the relationship between the middle layer of thoracolumbar fascia and the lumbar plexus. And we can trace that to the embryology. So embryology has shown us how the middle layer of the thoracolumbar fascia is developed. It develops within or together with the intermuscular septum that you see here. And this is also where the nerves branches out from the neuroectoderm out and to form your nerve roots. Now, last but not least, again, to appreciate how close is the relationship of the thoracolumbar fascia to your nerves, to your spinal cord rather in this state. So if I were to image the structure on my right here on ultrasound, you can see the two spinous processes. Again, on ultrasound, these are the two spinous processes, okay, which again seen below. So between the two spinal processes, you've got the interspinous ligament. On top of the two spinous processes, you have the supraspinous ligament, and on top of that, you have got the thoracolumbar fascia here, now visible on ultrasound. Okay. This diagram on the left shows how the connection is between thoracolumbar fascia and supraspinous ligament. They are quite adjacent and quite intimate, and how supraspinous ligament, interspinous ligament, and even ligamentum flavum through this gap here are also connected. Therefore, pathology of the thoracolumbar fascia may very well affect this spinal cord through its connection into the ligamentum flavum. I'll just skip that slide because it's represented here as well. So now we're looking into function, how thoracolumbar fascia is a very interesting structure that literally connects our upper limb to our lower limb. So we all know that whenever we stand and walk, there will be a gravity force towards down into one limb. And we also learn in biomechanics that there is also an equal and opposite force that goes up, and that is the ground reaction force. So this schematic diagram on the right represents how forces goes from one limb to the contra lower limb through the thoracolumbar fascia, or in here it's called thoracodorsal fascia, and whereby latissimus dorsi is connected to the upper limb, and it's also connected to the lower limb through the gluteus maximus muscle onwards through the thoracolumbar fascia. So we now can imagine how thoracolumbar fascia is really an important bridge that connects our limbs and our torso, and it's very important in high-level activities like running. So in a review, it's now being recognized that you can somewhat visualize this thoracolumbar fascia either through ultrasound and MRI. And because my day-to-day work is through ultrasound, I'll show you an example of a young gentleman who actually presents with bilateral knee pain. It's quite interesting. Now, if you were to be able to see again his movements, and I'll try that again by just scrolling backwards and forwards, you can see the ultrasound representation on the right-hand side. Already from the outside, you can see it's not symmetrical. You can see some abnormalities on his right paraspinal muscles and fascia thickening. And this is what we're referring to as what is visible as fascia. And ultrasound, the beauty of it, you can do a dynamic assessment as well. I'll come back to that case at the very end to show some clinical relevance. Another thing that can happen is also being not directly related to thoracolumbar fascia is the nerves that travel in and out of the thoracolumbar fascia region. So thoracolumbar fascia is attached to the iliac crest, and there's an osteofibrous tunnel that crosses the iliac crest where the cluneal nerves, 3 of them, passes on top. So if you were to see the cadaveric dissection here, the dotted red lines is where the thoracolumbar fascia will be attached on the iliac crest. And the white dots is where the cluneal nerves pass and where it terminates at the very bottom here. And again, in ultrasound, we are able to see this by imaging on top of the iliac crest. Now, can you imagine if the tent, which is the thoracolumbar fascia, or the roof, which is thoracolumbar fascia, becomes very tight, you can compress on the cluneal nerves. And this typically presents as a pain that starts from the back, a little bit paraaxial, and radiates into your buttocks. Sounds familiar? Yeah, it may well just be clunar nerve entrapment from thoracolumbar fascia pathologies. So integrating what we understand about the structure of the human spine and how it moves through the tensegrity concept. Now we have a biotensegrity spine model that explains how the spine, well, if you're looking at what you and I can do, we just walk and stand. But if you look at contortionists, acrobats, gymnasts, and how they can move the spine to such an amazing degree, you can now appreciate the application of the biotensegrity model, where it's not a rigid spine structure. It's a structure that must move and does not snap. And that is where biotensegrity is shown in its beauty. Again, pictorially depicting one of the earliest human activities. You ever find this in cave drawings on Roman artifacts. You find people throwing a javelin, and that beautifully shows the position of the javelin thrower, beautifully shows the interaction that I've shown you earlier on of the thoracolumbar fascia and how force is transmitted, especially if you were to look at the picture A on top, how the force is transmitted from one limb to the contralower limb through the thoracolumbar fascia, which has a tensile strength and also the flexibility. All right, I'll show you a snippet from Dr. Brad Fullerton. You can just find this on YouTube. So he's basically doing an MT-Can test on obviously an athlete, a very muscular athlete. And he wants to show you, how this guy is very strong, and he's not doing, the athlete or the patient is not doing this by purpose, but he's unable to resist the examiner's hand during speed test and MT-Can test. So this gentleman presents initially with shoulder pain that was treated with regenerative medicine, and it's healed quite well in terms of function. He's able to do all the function, but he still finds that on high level activities, he's unable to do it. So next video now shows the concept of pre-stress. So this pre-stress is an important concept that we want to know if you were to treat fascia. Let me just play that. So now you see an attendant applying a bit of tension on the fascia, and here we're looking at thoracolumbar fascia, and lo and below, the patient is now able to do it when he was not able to do it. Of course, you'll say, yeah, he's acting, but you have to take it at his account, at Dr. Brad Fullerton's account, that with introduction of pre-stress, the myofascia tension or bridge can be restored, just like how you tighten a mast, a sails rather, on a mast, and that doesn't go more flapping and it becomes more taut, and you're able to use the sail. So with this concept in mind, there are many fascia-targeted interventions that has been invented. The superficial fascia has been targeted with taping. It can be targeted with cupping, Graston, or scraping, gua sha. But the deeper thoracolumbar fascia has to be dealt with ultrasound-guided intervention for safety purposes. So here I'm demonstrating the same patient I've showed you earlier on with the pain, and we were going in to separate the structure that was stuck because there was abnormal movements of the erector spinae muscle, and the erectus and this abnormal movement has led to presentation of knee pain because of the close relationship between the muscle and the lumbar plexus, as I showed you earlier on. So the pain is referred to bilateral knee. So after the release of the thoracolumbar fascia, the patient reports almost immediate relief of the bilateral knee pain without needing any more interventions. So to conclude, where are we going right now with regards to the use of these two novel findings that I've mentioned, which is the EMG and the fascia? Is we can use EMG guided motor control training or biofeedback and fascia focused therapy, either in the form of tightening the fascia and introducing pre-stress through either regenerative injections or through physical modalities. We can also track our outcomes, not just with traditional oswestry or patient reported questionnaire, but also through repeat SEMG, surface EMG, to detect FRP and to record the FRP progress, and also through ultrasound guided assessment of the patient's back. In the future, we can always bring in AI, as AI is very good at detecting patterns, and we can introduce machine learning to the identifying which patients having what kind of pathology as the data increases, and also prognosticating whether we can treat SEMG patterns like how we treat ECG, and that's probably where I hope it will go. the use of elastography for fascia stiffness mapping. So for those who are doing ultrasound imaging, they probably understand elastography is a measurement of stiffness of a soft tissue, so we can actually see how stiff is a fascia is and grade the stiffness and correlate that to other other outcomes like pain and function. And of course, RCTs, we need more of that to see the effectiveness of our intervention. So I'll leave you with a take-home message, which is we can no longer accept low back pain being non-specific. We have to be specific in order that we can treat. So if this is after we've ruled out reflex, we know that it's not involving the nerves, it's not potentially going to hurt or kill the patient, then we will need to look into where is the specific cause of this low back pain. If it's coming from the myofascial system, myo being muscle, facial being fascia, okay, myofascial system, then interventions needs to be targeted towards that. The flexion relaxation phenomenon detected through the surface EMG is a functional biomarker. It's not just a static image of the patient. It sees the muscles in action, quantifies it, and tracks it. And with the understanding of biotensegrity, allows us to have a wider approach to the patient, either with or without injections, to improve not just the symptoms, but also patient's functions. With that, thank you so much. Assalamualaikum.
Thank you, Prof. Anwar, for that. I think a very thought-provoking journey into the complexity of low back pain, from the fascinating interplay of the muscle currents and disability to the often overlooked role of fascia, its tensile strength and other roles in our bodies, which many of us actually have underestimated until today. So you've also reminded us that managing low back pain isn't about chasing images or rigid algorithm, but about decoding our own body electrical language and myofascial, system, and try to integrate it into the management and rehabilitation care. So we do have questions, but I don't know, it's 9:05. I'm not sure whether we can allow one question. There's a question here from the audience. I think one question from, I think this is from Prof. Sarah, asking about how often does low back pain presents with sciatica. So that's one question. And another question is pain from fascia diagnosed mainly using ultrasound or based on EMG or exclusion of other causes? I think those two will be the main question that if you can answer in probably 1 minute. Thank you.
Thank you so much. Okay, thank you, Prof. Sarah, for that. So sciatica, if I can just redirect your attention, sciatica is a symptom. You have sciatica and pseudosciatica as a potential cause. So sciatica, as we know, is a symptom that starts back pain, that starts mainly in the buttocks and goes down into the lower limbs, all the way to the end. Stopping halfway through at the knee is not sciatica. So if you have sciatica, it's originally from the nerve roots. Pseudosciatica, which also presents like sciatica, may or does not have positive straight leg raise test, but does have the symptoms like sciatica, is caused by so many other causes, things like piriformis syndrome, sacroiliac joint irritation, sacrotuberous sacrospinous pathology, tendon sacrospinous sacrotuberous pathology. I've even seen it in hamstring injuries because of this, the position of the sciatic nerve in the subgluteal space, very, very close to the bicep femoris and the semi-M, semi-T tendon. So again, how common it is? I would say getting more common. Again, whether this, if you are asking whether it's coming from the nerve roots and compared to those pseudosciatica, I would say nerve roots through sciatica, 5%. The rest of the 95% is still the pseudosciatica. Okay, Prof. So that's question number one.
Question is pain from fascia diagnosed mainly using ultrasound or based on EMG or exclusion criteria?
I will always say that we will stick to history taking and physical examination. Now, how do we suspect? And I always get this question, how do we suspect this is fascia? This is where, and I always remind my trainees, you must develop your history taking and especially physical examination to the point that you're very confident with your examination history and patient's findings does not correlate. So this is when we have to look, oh, it's not your sciatica, like just now if I use the example. That definitely does not look sciatica, it does not look radicular, or it does not look like a radiculopathy. So then we have to look. The problem is when you do imaging, you can't see a lot of things that your mind is not ready. If you do not know, you won't really look for fascia. So then the next question, how do we look for fascia? On MRI, as I've shown you just now, there's so many things. You cannot ask the radiologist, just take a small little snippet of the skin, just underneath the skin and 5 centimeters in. No, you get a full cut. But on ultrasound, and the beauty of ultrasound is you can adjust that thickness. You can go all the way down to the kidney. You can come up all the way down just under the skin. That's number one. Number two is you can do dynamic tests on patients. So you saw the gentleman that I asked him just to move left and right. You can even see even before. I know the video was quick. Well, we only have half an hour. But you can see the difference, the asymmetry between the erector spinae muscle, even before he starts. And when he starts moving, the goal, the money shot was there. Basically, you can see that the contraction was not the same. The fascia glides strangely, and you you can do the test that Dr. Brett Fullerton has shown you. So we did a test across his lumbar erector spinae muscle in the lumbar region, and he was able to do a functional test, a single leg stand. It's nothing difficult, single leg stand. So he was wobbling before we did that, and then after I just put my hand on the thoracolumbar fascia, giving him pre-stress, he was stable, and then I tape it. I just taped the two fascia close together, hands free, my hands off the patient. He was able to do the test. So yes, the findings as or rather diagnosing fascia is still developing, but it's getting more and more concrete. We are writing it up. So hopefully keep your eyes on it, okay? As the more evidence comes up. Thank you so much.
Okay, thank you. Thank you, Prof. Anwar. I think another question is just how to refer. I guess referral is really based on, we can refer to the clinic, right? The MSK clinic
Yes.
or APCR
Yes.
clinic. There's a rehabilitation
Yes.
clinic. If you're not
Yes.
sure what code it is, just write a memo referral to the musculoskeletal rehabilitation clinic, and then they will, screen the patients accordingly and give to the right
Right.
clinic.
Yes, very
For
easy to remember,
specified
Prof. The
patient.
code is
Yeah.
James Bond 007. So it's
Uh, uh,
RE06007 is my code for MSK.
Yeah,
Thank
for
you.
those. Okay, all right. Thank you. I think we
Thank
have
you.
exceeded about 9 minutes from the original time. I'll give it back to the organizer. Thank you so much, Prof. Anu.